Good morning and welcome to the Public Health and Minority Health Disparities Subcommittee. It is March the 11th, Monday, March 11th of crossover week. Welcome to crossover. We have a number of bills on the docket that we're going to start today, get through as much as we can. And then we also have subcommittee tomorrow as well. So I want to start with a couple of bills that we are holding, just so that anyone who is here for those bills doesn't have to stay. We're holding House Bill 1171. We're going to hold that over to tomorrow because we've got some more information on that, and also House Bill 822. So House Bill 1171, non-prescription drugs and devices, provision by registered nurses, sale of contraceptives through automatic devices. We're going to hold over for tomorrow's subcommittee, and also House Bill 822, Maryland Medical Assistance Program, employed individuals with disabilities. We're going to hold those two bills over. So we are going to start with House Bill 1051, Maternal Health Assessments, Referrals, and Reporting, Maryland Maternal Health Act of 2024. Erin, if you can talk us through the bill and the amendments, and then I think we have the department is here as well.
Okay, there is a reprint that's been provided, and it's actually an unnumbered reprint. So it's the one that says final reprint. It doesn't have a number with it. I apologize for that. And that reprint includes bills, amendments that are being proposed by Delegate White Holland. So the bill requires a provider who receives reimbursement from Medicaid for obstetric services to complete a prenatal risk assessment form for a patient.
That's muted.
And the birthing facility where an infant is born to complete a postpartum infant and maternal referral form.
Marie, Marie, can you mute Marie Grant? Thank you.
And submit the form to the local health department and the Secretary of Health to develop a Maryland report card for birthing facility maternity care for each birthing facility in the state. The Maryland Department of Health, in collaboration with stakeholders, must study incidents of severe maternal morbidity in the state and report its findings to the General Assembly by December 1st, 2025. So moving on to the reprint that was provided. Sorry. I had it up and now I'm losing it. Okay. So in the bill, it has several different sections. The first section requires a provider who receives reimbursement from Medicaid for providing obstetric services to a patient to complete a prenatal risk assessment form for the patient during the initial visit with the patient. So the requirement that the provider complete this form during the third trimester of the patient's pregnancy is removed in the amendments. In the next section, in 19310.4, which is on page 3 of the reprint, this provides that if a newborn is delivered in a hospital following a high-risk pregnancy, the hospital must complete a postpartum infant and maternal referral form and submit the form to the local health department for the county in which the birthing parent resides. The amendments to this section come in around line 20, where it provides that the hospital must call the birthing parent at least 24, but not later than 48 hours after discharging the parent. And then some of the implementation is pushed back from May 1st to October 1st. And that's the requirement that each local health department submit to MDH a report that includes the number and type of referrals made based on the referral forms. There is language stricken that would have prohibited the department from providing Medicaid reimbursement to a hospital for services related to delivery if the hospital did not comply with that provision. So that language is stricken. The next section on page 4 is just a repeat of the hospital requirements for freestanding birthing centers. And then if you move down, is on page 5 is the requirements for the Maryland report card for birthing facility maternity care, which will be developed by the Maryland Healthcare Commission. And then further down on bill page 6, in section 2 and section 3, this is amended language requiring a few studies. Under section 2, it requires each hospital and freestanding birthing center to participate in the severe maternal morbidity surveillance and review program that is coordinated by the Maryland Maternal Health Innovation Program to identify contextual drivers, risk factors, and causes of severe maternal morbidity, and make recommendations to reduce the prevalence of severe maternal morbidity in the state. And then they would report to the General Assembly on those findings. And in section 3, there's new language that requires the Department of Health to convene a work group to study and make recommendations regarding appropriate workflows to connect patients who are pregnant or have given birth to community-based providers and supports. And then it says who the work group should include, and it requires the work group to report its findings to the General Assembly. And then there's also language that would delay implementation of the bill's requirements to July 1st, 2025.
Thank you. Do I have a motion on the amendments?
Move the amendments.
Second.
Okay, it's been moved and seconded. Let's go ahead and open it up for discussion. Ms. Laval.
Hi, thank you for that. I have two small things I wanted to put in front of folks. I think in general, they don't change the intent, but just to maybe clarify a bit. On page 5, line 26, where it talks about age-adjusted rates of maternal complications. And then right before that, what was also added was adding stratification by age and race. We want to keep the stratification, but it's not common to do age adjustment. And in a way, if you adjust rates for something, you can you don't have as much clarity on what's happening there. So I would say that we don't do the age adjusted rates, but just do the stratification. And then I guess one other thing sort of related to that would be small is that I know as we work with MHCC to develop this report card, they may need some flexibility about small cell sizes. I don't know if that needs to be built into this language or if that's just assumed. So that's one. I have a second one, which is kind of in the same vein. This is on page 6, the language about requiring every hospital to participate in the SMM reviews. I wonder, do we want to clarify that we want every birthing hospital? Because hospitals that don't have deliveries, I'm not sure it would make sense for them to participate. Those were the two things I wanted to raise.
Okay, thank you. Can you just point out the line? It's taking me a minute to get there. On page 6.
On page
24.
Thank you.
24. Thank you very much. I just got there. Yeah, I think we should discuss that just because that are we Delegate White Holland.
Thank you, Madam Chair. And Tracy, thank you for elevating that. Starting on page 6, I think the intent was around birthing hospitals to participate in this. And so I think that makes sense. I'll go back to the rate issue here, and I believe as it relates to concerns around small numbers, I believe that the health department may have some recommendations on language, and I see Dr. Crum shaking her head as well. So I don't know if we want to pivot to the health department, as they may have some recommendations on how that and language on how that can be addressed.
Yeah, and I know we've got Dr. Kalyana here, as well as Marie Grant and Elizabeth Crum. So Dr. Kalyana.
I'm happy to respond to that. So one of the suggestions we have is to for that data piece to insert in accordance with relevant data suppression rules linked to data source to get at that piece of statistical suppression when the cell size is small.
And I see Tracy nodding her head and thumbs up. Aaron, did we capture that?
Yeah. I'll get that.
All right, thank you.
And I had a few more comments if then now is the time, or I can certainly wait.
Now is the time. Now's when
Okay.
we're having the discussion, so.
All right. So a couple of other items. So one of the section 3, the work group piece, wanted to kind of push into that. We have a number of work groups already. This would be another one on top of that. And actually, we've got the HRSA Integrated Maternal Health Services Grant, which requires us to start a new work group involving prenatal care providers, birthing hospital staff, local health department staff, Medicaid, MCOs, CRISP. And so we think that's going to get to a lot of it. I know that the piece that's the thing that they're really going to be focusing on is a lot of the prenatal risk assessment, the PMER forms, but it does get to a lot of the work that we're trying to do here. And so we'd really like to avoid another work group since we already have to stand one up as part of our grant to do this work to begin with.
And Dr. Kalyanaraman, the reports of that work group, where do they go? What is the reporting around that group?
So that report, and I'm going to look to Dr. Crom here for a second, but we've got to submit that by January 31st. Our first report has got to be submitted by January 31st, 2025. Is that a report to HRSA, I believe? But we'd certainly be happy to share that report. There's no reason for us not to.
So I was going to say if we can share that with the committee, and I see Delegate White Holland's hand has gone up. I think that probably gets us there, and we can consider just taking that section out. Delegate White Holland.
Yes, I was about to say, certainly we don't want any, we don't want to duplicate any existing efforts. I think as to Chair Bagnall's point, it would be helpful to not only get a report, but to really get a sense of what will those workflows look like or what will be decided upon. So I think as you convene all of those that you've identified as well, others, especially thinking about how our community-based providers may fit into this, fit into this particular space, it'd be really helpful to just to hear back and have a feedback loop about what those workflows look like. So that's all that I would request. But, certainly take this amendment as friendly.
All right. And I've just got Cloran in the chat, and I don't.
Good morning, Delegate Bagnall. It's Kathleen Lochran. How are you?
Thank you. I was like, I know if it wasn't so early, I would have put it together.
It's
Sorry,
fine.
Catherine,
It's
go
fine.
ahead.
I appreciate it. Thank you for your time and your efforts. And thank you again to the sponsor of the legislation. WellPoint Maryland fully supports this bill and the intentions of the bill. We actually had submitted the amendment to the sponsor regarding age adjusted. And that language came directly from my plan president, Dr. Gray, who felt it was an important component for the MCOs to have the age adjusted. So I don't have the benefit of a committee reprint in front of me. And I'm not sure if the gentleman from MDH just spoke to that language in his general comments when he began. So I will defer to MDH if they think that they're taking care of this, but I just wanted to highlight, particularly on behalf of my plan president, Dr. Gray, that this was something he felt was important to have, this specification. Thank you.
Thank you, Catherine. And Dr. Kalyanaraman, do you want to just speak to that one more time since Catherine doesn't have the reprint?
Yeah, so I was speaking specifically to the data suppression issue, not the age adjusted issue. But I think we can go back and forth on this. And I might be speaking a little bit out of turn, but my inclination is to allow the folks who are doing the stats to figure out what's going to be the best way to handle this. And in certain settings, we include both raw and age-adjusted data. I think that if this is going to be a back and forth issue here, it might just be one where we can leave it up to those who are doing the analysis. I mean, either way, we're going to get a report of this data. That is without question.
So if you're telling me, and I guess I'll look more to the sponsor and the chair as well, if the language in the bill gives flexibility to allow for age adjusted. So to his point that, this is something that needs to be decided issue by issue, then I think I'm okay with that. I don't want to lose the ability to do age adjusted where it's appropriate or where certain stakeholders like WellPoint may feel it provides additional clarification and opportunity for us to serve those members.
No, and I appreciate that. And I'm going to go to the bill sponsor again, Delegate White Holland.
Thank you, Chair Bagnall and Kathleen. I appreciate you elevating this. We do have age-adjusted rate included around complications. So that is included. And I think what they were speaking to is around how and disaggregation as well, because I know that is a core aspect too by race and age. So those aspects are included in the reprint and in the bill. I think they were speaking to how some of these outcomes are so very small and could very well be identifiable and concerns about that. And so their proposed language would make sure that this bill is in alignment with in how they already report those particular numbers and rates. I hope that provides some clarification, but again, the intent is still in the bill and some of that language around age adjusted.
So I think that does help. I was responding to MHA's comments about taking that language out, because that was one of the items identified by the representative for the Hospital Association that they wanted stricken, was the age adjusted.
And Ms. Laval, do you want to?
Yeah, I just want to make clear that we want to have information about rates and complications by age, because age is a contributor to where the complications are. So we want that light to be shown on that, just like you would disaggregate by race. You want the light shown upon that. The reason that I come to this with a preference for showing the disaggregated rates is you have actually more information about that. As soon as you add the adjustment in, it sort of buries it. So, but it could have, there could be challenges with the small cell sizes. So I think having the flexibility is the way to go. I just wanted the opportunity to say, it's not like we don't want age to be a factor in there. We absolutely do, so that we can understand the data better. Just maybe, saying that there's the flexibility there. And I didn't want anyone to think that we don't want that light shined on age, because it is an important factor.
No, and I appreciate that. And it sounds like we have the flexibility, but that maybe having this language in there remove some of that flexibility when we're talking about the very small subsets. So I'm going to turn to our council now and just make sure that we are maintaining the flexibility, but maybe not keeping this language in this section.
Okay, I mean, I can adjust it accordingly following these conversations.
Thank you.
Recirculate, yeah.
So because we are going to make a few adjustments, I don't want to ask the subcommittee to vote on this today, so that we can get a reprint in front of us, but we can vote it first thing tomorrow. But I do want to get any outstanding questions answered. Dr. Kalyana-Raman, you had a hand up.
Yes, did have two additional items that I wanted to bring up.
Okay.
In terms of proposed amendments. One is the page 6, line 24, coordinated by each hospital and freestanding birthing center should participate in the severe maternal morbidity surveillance and review program. We'd like to strike the next part, which is coordinated by the Maryland Maternal Health Innovation Program, the MD-MOM program. And that's mainly because that's a grant-funded program. But the department are responsible for that. And for the time that MD-MOM is running, if that's the appropriate venue, that's what we will be putting forward. But that may shift, and we don't want to put in statute something that is grant limited.
So that we have the flexibility to put it under the appropriate, house it in the appropriate, venue. Delegate White Holland, is that?
No, that makes sense. I mean, it's a grant program, you know, this could very well exist beyond 2028, which is when the grant funds run out. So I think it makes sense just to make sure that this is baked into law in the right way.
Got it. And Aaron, you've got that?
Yes.
All right.
And one more item, Delegate
Yep.
Daniel. And then on page 6, line 29, there says, let me find my spot. The work group shall report its findings, and we'd like to add of evidence of quality improvement efforts into the hospital findings based on the SMM reviews, and that's that severe maternal morbidity review that we're talking about, just so we're explicit about identifying what these QI efforts are at the hospital level as well.
And can I ask you, very kindly to email that language to Aaron, just to make things a little easier so that we're making sure that we're
I
capturing.
got it during this meeting. I have it.
You're awesome.
They're awesome. They gave it to me.
Oh, perfect. Well,
I just received it.
Thank you all for your hard work on this. I want to see if there are any other outstanding questions from the members. We are going to hold this bill today. And I think we're going to be ready to move it first thing tomorrow. But I want to make sure that I'm getting you a reprint so we are clear on what we're voting on. So I'm looking to the members, see if there are any other questions, anyone else who wants to be heard on this bill. All right, thank you very much. We will hold this bill pending the reprint tomorrow. And we are and thank you all for continuing to do such good work. Because I know we're going to be moving quickly this week. So speaking of moving quickly, we are going to move to House Bill 1078. This is the Maryland Medical Assistance Program remote ultrasound procedure and remote fetal non-stress tests. Aaron, if you can talk us through the bill.
The bill requires Medicaid to provide remote ultrasound procedures and remote fetal non-stress tests using current procedural terminology codes if the patient is in a residence or location other than the office of the patient's provider, and the provider follows the same standard of care that the provider would follow when providing services on site. Medicaid must provide reimbursement for a remote fetal non-stress test in the same manner as an on-site fetal non-stress test. A remote fetal non-stress test must require the use of remote monitoring solutions that are cleared by the Federal Food and Drug Administration for on-label use for monitoring fetal heart rate, maternal heart rate, and uterine activity. Medicaid is also required to issue guidance for providers to implement the bill. There were no amendments presented at the bill hearing.
And let me, if I can get a motion on the bill.
Move the bill.
Second.
Been moved and seconded. Are there any questions, concerns, discussions on this bill? All right, it's been moved and seconded. All in favor, say aye.
Aye.
Anyone opposed, go ahead and raise your hand in the chat. Thank you very much. So it has been moved unanimously. And we're going to move to House Bill 1048, Behavioral Health Advisory Council and Commission on Behavioral Health Care Treatment and Access Alterations. Aaron, if you can talk us through the bill and the amendments.
This is a departmental bill that requires the Behavioral Health Advisory Council and the Commission on Behavioral Health Care Treatment and Access to work in conjunction with one another, including by coordinating with one another on their annual reports and meeting jointly at least 3 times per year at mutually determined times and places. The bill alters the membership in terms of the council and requires the commission to make specified recommendations regarding the integration of somatic and behavioral health services in Medicaid. There is a reprint that's been provided, and that reprint conforms the bill to its Senate cross-file as it passed the Senate.
And did that passed unanimously in the Senate?
I believe it did.
Thank you. Can I get a motion on the amendments?
Second.
Been moved and seconded. Let's go ahead and open it up for discussion. Mr. Martin, I saw your hand in the chat.
Yeah, thank you, Madam Chair, and everybody here. And we're excited to again move forward with this bill and have to start having a conversation, and appreciate taking the amendments in the Senate, especially the one that we offered in the House too, to kind of push the date back 6 months to make sure that we have enough time to talk through everything. We did offer one additional amendment in the House that we just neglected by accident to include in the Senate, and I wanted to see if this was something that the subcommittee would be open to. And it's adding the Secretary of Aging or the Secretary's designee to the membership of the commission. The commission has the legislature, when it established this commission, established 4 standing work groups, and one of them is a geriatric behavioral health work group. And the Department of Aging is really an important partner in all of our work to make sure that appropriate behavioral health services are available to folks of all ages, including older adults. And it just seems kind of a glaring absence to not have the Department of Aging as part of this effort. And so would request an amendment to add the Secretary of Aging or their designee to the membership of the commission.
Murray Grant, go ahead.
Thanks, Delegate Bagnall. The department would take that as a friendly amendment. We don't have any objections to
that. Judge Kroll, saw your hand up.
Delegate Bagnall, good afternoon, good morning, rather. Judge Kroll's a good promotion for me, but I'll take just Mr. Kroll, but maybe one day, I'm not sure. But the Maryland States Attorneys Association will also want the friendly amendments be included in this bill.
Well, I'm sorry. Can you state the amendment again?
To include the Maryland States Attorneys Association as part of the commission.
Sorry, I just didn't have that amendment. So
we'd asked for it in the hearing. I don't know if it's gotten a written amendment or not, but I'm just requesting it this time.
Gotcha. Okay, thank you. Murray Grant.
Thanks, Delegate Bagnall. I love that so many folks want to be on this commission. It's big already, but that all being said, I think we can take that as a friendly amendment too. I think as the commission looks at issues that impact behavioral health and our correctional system, it may be beneficial to have that representation on some of that work.
All right, we're 2 for 2. Delegate Alston.
So I'm trying to catch up here, but is the public defender's office on the commission?
I believe they are already represented, Delegate Alston. I'll confirm, but I'm pretty sure they are on there.
Okay. If not, I would just say that we can't have the state's attorney's office and not have the public defender's office.
They are on there, and we just want to be included too. They are.
Okay, I just want to make sure.
Absolutely.
Thank you.
No, and I appreciate that, Delegate Alston. Aaron, have you got both of those?
I do, yes.
Move all the amendments, move them all.
All right. So we have another motion to move all the amendments, including the 2 friendly amendments. Do we have a second?
Second.
All right, they've been moved and seconded. All in any further discussion? I want to make sure I've captured everything. All right, all in favor say aye.
Aye.
Anyone opposed, go ahead and raise your hand in the chat.
Move the bill as amended.
Move the bill as amended. Do we have a second?
Second.
All right, it's been moved and seconded. All in favor say aye.
Aye.
Aye. Anyone opposed, go ahead and raise your hand in the chat. All right, it moves unanimously. It will not be in the same posture as the Senate, but I think hopefully they will take our amendments as friendly as well. So that is House Bill 1048. We are going to move to House Bill 969. Thank you all for your hard work. And 969 is death certificates, cause or manner of death, determinations, requirements after change or correction. And Erin, if you can walk us through the bill and the amendments.
Okay, there was a reprint provided of this bill, and that incorporates amendments that are being offered by the bill sponsor, who is Delegate Bartlett. The bill requires a medical examiner, if the cause or manner of death on a death certificate is amended or corrected to be undetermined or homicide, to provide notice to the state's attorney and local law enforcement where the body was found of the different finding or conclusion on the cause or manner of death. The medical examiner must also request that the Secretary of Health send the person in interest a new certified death certificate at no cost. An assistant state's attorney with knowledge of the case in which the victim's cause or manner of death was amended or corrected must meet with a person in interest regarding the request that the office of the state's attorney pursue an investigation into the circumstances of the victim's death. At the meeting, the assistant state's attorney must explain the justification for not pursuing an investigation into the death despite the amendment or correction to the cause or manner of death on the death certificate. The amendment in the reprint provides that if a law enforcement agency is notified by a medical examiner under this bill, that the law enforcement agency shall reopen or reinvestigate an investigation involving the death of a victim whose cause or manner of death was amended or corrected to be undetermined or homicide. And, hold on, may not close a case that was reopened or reinvestigated under the previous section until at least 20 years after the law enforcement agency was notified.
Move the amendments.
We have a move. Do we have a second?
Second.
All right, they've been moved and seconded. Thank you, Delegate Hill. We have a hand from Delegate Chisholm, followed by Delegate Rosenberg.
I want to make sure I understand the amendments. So right now, if the death certificate says suicide and then it goes to the medical examiner and the medical examiner just puts undetermined, or then the case goes back and needs to be reopened up by whichever law enforcement agency was handled. Am I correct on that, Aaron?
Getting that. And then Delegate Bartlett is on
I was
the
going to
call.
say Delegate Bartlett's here. Delegate
Yes.
Bartlett, do you want to go
Okay.
ahead and speak to that?
Delegate Chisholm, you are correct in part. So it's not for all cases. It's only for those cases in which the family or the person in interest has won an appeal, essentially, on the change. There were, in the past 2 years, there were 6 cases that would be affected by this bill.
Okay, thank you. I just want to make sure I understood why we were doing it.
Delegate Rosenberg.
Yes. This may have been answered, but I just want to be clear. To what extent is this a public document under the PIA, Public Information Act? The death certificate and the dissertation.
You know, a death certificate can be requested by anyone who's willing to pay for it. I am not sure. You mean the death certificate itself, not anything else, just the death certificate, right?
Well, and what we're talking about here, what the medical examiner has determined.
Yeah, the medical examiner's office has some criteria with respect to receiving like the full autopsy and things of that sort. I don't think they give those out freely to the public. I think it could be subject maybe to a PIA. I'm not quite sure. If you give me a second, I can probably grab the answer. I don't think we have anyone from the public defender's office here.
And I just saw Marie Grant's hand go up, so maybe she has an answer for us.
Yeah. Thanks, Delegate Bagnall. No answer, unfortunately, but I can say we can get the answer to that pretty quickly for you all. Because it lives with the medical examiner, it's the PIA requests come into the Department of Health.
I don't want to hold the bill up. I just was interested in that point.
But it wouldn't change, this bill wouldn't change, whatever the status is for that now would be the same, correct?
Okay.
Right. That is my understanding, Delegate Hill.
Thank you. Thank you.
Thank you. And Delegate Alston.
I was just curious if the public defenders had an opportunity to see the amendments and had they weighed in.
You know, I went, interesting you would ask that. I didn't go to the public defender because they're not in the bill and they didn't weigh in. They usually, if they have a problem, they would have, said something to let me know. It's actually something that, so no, I don't know the public defender's position. I only went to those who are in the bill, medical examiner, state's attorney, and law enforcement. And I was shocked that I got everybody on the same page, so I stopped there.
Okay, thank you.
And thank you to everyone who, I see Steve Kroll, thank you to everyone who did, did help with getting me feedback on the bill. I appreciate it.
Well, thank you. Thank you for your advocacy, Delegate Bartlett. I know this has been an ongoing concern within our county. So we have the amendments have been moved and seconded. Any further discussion on the amendments? All in favor say aye.
Aye.
Anyone opposed, go ahead and raise your hand in the chat. On the bill as amended, can I have
The bill is amended.
Second.
All right, it's been moved and seconded. Any further discussion? All in favor say aye.
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 Anyone opposed, go ahead and raise your hand in the chat. All right, it passes unanimously. Thank you very much, Delegate Bartlett, for being here to help us understand it as well.
Thank you.
And we're going to turn now to House Bill 411, which is Public Health Opioid Overdose Reversal Drugs Standing Orders. Aaron, if you can walk us through the bill and the proposals from the department.
This bill requires a licensed healthcare provider, when issuing a standing order for an opioid reversal drug, to allow an individual to choose any formulation of any opioid reversal drug approved by the Federal Food and Drug Administration. It's my understanding that the department has proposed amendments that they're here to discuss.
All right, Marie Grant, go ahead.
Thanks, Delegate Bagnall. Thanks, Aaron. Yeah, so we met with Vice Chair Collison and Eric Galley, who's one of the advocates on. And his hand is raised. so I will not speak for him. But we talked about amending the bill to be a study and report back from the department on the types of opioid reversal drugs available, and if they're not included in our standing orders, why not? And so just so there's a lot of clarity and transparency in how we're moving forward. We're still working out that language. I know that even just as of a few minutes ago, Mr. Galley and I were talking about the cadence of the reporting as well. So I'm hopeful that we can work it out by tomorrow morning, but that's the status from my end. And
all right, great, thank you. Mr. Galley. Mr. Galley, we can't hear you. You're not on mute, but we can't hear you.
Hi, is that better?
That's better.
Good morning, thanks. I'm in my car running around, but I'm glad I was able to get on. We're okay with the study. We would just ask that it be a yearly thing, not just one report, because if we get a report this year, we're not keeping up with all of the new things that are coming in and all the new data. So we're very comfortable with the study position. We just ask that at least for the next few years that it be an annual thing.
The yearly review, and I see a head nod from the department, so it sounds like they are amenable to making this a recurring review.
yeah, I like the idea, like Mr. Galley just said, over the next few years. So maybe not in perpetuity, but perhaps for the next 3 to 5 years. But we're working that through.
All right, well, we will hold this bill. Again, if we can get those amendments today and get the reprint out to the subcommittee so that we can vote the bill tomorrow, that would be greatly appreciated. And thank you very much for all your work on that. We are going to turn to and Mr. Galley, please be safe. As always, I appreciate you being here. We also want you to be safe. House Bill 1293, Maryland Department of Health Public Education Campaign on Prostate, Lung, and Breast Cancer Prevention. Aaron, if you can talk us through the bill and this and the proposed amendments from the department.
So this bill requires the Maryland Department of Health to develop and implement a 3-year public education campaign on prostate, lung, and breast cancer prevention that targets communities disproportionately impacted by those cancers. The campaign must provide educational information, promote participation in clinical trials and studies in cancer screenings, and provide information on legislation that reduces cost barriers to prevention services. The department must set measurable goals for the public education campaign and submit annual reports on the status of meeting those goals to the General Assembly by January 1st, 2027, and annually through January 1st, 2029. For fiscal 2026 through 2029, the governor must include in the annual budget bill an appropriation to MDH from the Cigarette Restitution Fund for the Public Education Campaign. The total amount appropriated from the fund for the public education campaign over that period, as well as any funding that may be appropriated in fiscal 2025, is capped at $2 million. I know MDH had amendments that they were proposing at the bill hearing, and they're here to discuss the status of those amendments and their communications with the bill sponsor.
Yes, thank you so much. To our members, I did reach out to the bill sponsor to try and get those amendments. I was not able to connect with her, so we're not going to vote this bill today because I want to make sure that we have some consensus on those amendments. But if I can ask the department to speak to what we're looking at conceptually, and then we'll get the reprint to the subcommittee. So who's here to speak on this?
I will be happy to do so. Excuse me.
All right. Thank you, Dr. Kalyana. Go ahead.
So in concept, and I don't have the amendments right in front of me, but in concept, what we're talking about is adjusting some of this to focus on one, making sure that we're putting out a focus on prostate cancer and funding to do that, considering that's probably one of the bigger gaps we have, to strike the language around research studies. That's really not something that we tend to want to promote, mainly because that's the domain of others, right? We want to provide clear guidance around screening and what is currently available for folks. And then adjusting some of the funding. We believe we can do this with less funding over 5 years. So we want to adjust that down to approximately $750,000 over the 5 years to decrease that fiscal note. Those are in broad strokes the amendments that we're looking for, and we'll be happy to speak on any of the specifics.
And Dr. Kalyana, this has been in concert with the bill sponsor.
Yes, we have been talking to the bill sponsor, and we've been talking on the Senate side as well with the sponsor there.
Okay.
And sorry, one last item. We also wanted to move out the implementation date, mainly because we would have already obligated funding for fiscal year 25, so we want to start this with a new fiscal year in 26.
Okay, thank you. And if I can just ask you to clarify, because I'm afraid you froze on my screen. You had mentioned a focus on prostate, but we're not eliminating lung and breast cancer prevention education from this bill.
That is correct. We are not, but we would be leveraging current work that goes towards that.
Gotcha. Okay, thank you. Any other questions from the members? Okay, we're going to hold this bill so that conceptually Delegate Alston.
I'm sorry, the good old fashioned hand wave.
That's why I got you on my screen.
On the buttons. Yeah, I was just wondering what the feasibility, if anyone has considered adding, the University of Maryland has a school of public health literacy, I think it's what it's called. And I was just wondering if you all would consider including them in doing this, because they make things so plain and easy for regular people to understand.
We work with them frequently, Delegate Alston, on a wide range of projects, and we'd be happy to continue to work with them on this. So Cynthia Bauer runs that center and has been just a close collaborator across a range of projects.
Okay, thank you. So do we need to include them in this, or you'll just do it on your own?
We'll do that. I don't believe we need to, because we have such close ties.
Okay. Perfect. Thank you so much.
Thank you, Delegate Alston. Delegate Chisholm.
Thank you, Madam Chair. And I know the Cigarette Restitution Fund, I know, well, last year we brought in, we're projected to get about 136 million, and some now goes to cancer, some now goes to substance abuse, some goes to breast and cervical cancer. Is that just going to be up to the governor's discretion on where he's going to take the 2 million out? Who makes that determination, I guess, is where do they take it from? I know it comes from the CRF, but
Aaron or department, do we have an answer for that?
Madam Chair.
Delegate Hill.
I think Delegate Chisholm, are you, in your question, it sounded like there was an assumption that the whole fund has been dispersed into these others, and I think that's not true. There's still a balance in the fund, so it would come from the balance of the fund.
Okay, I was just wanting to make sure that if we pass the bill, that the money then is allocated exactly for what it's supposed to be allocated for, not just balance amongst all the other things that the cigarette restitution fund is supposed to do now.
Thank you. Thank you, Delegate Chisholm, and thank you, Delegate Hill for clarifying that.
Someone can double check, but that's my understanding.
Well, and we'll have time to confirm that, because we're going to hold this bill pending those amendments from the department. But I just wanted to, again, see if there were any other questions, concerns that we can address before we meet tomorrow. All right, seeing none, we're going to go ahead and hold that bill and go to House Bill 980, Public Health Opioid Restitution Advisory Council and Fund revisions. So Aaron, if you can walk us through this bill and the amendments.
So there's not a reprint of this bill yet because amendments are still being discussed, but the bill as introduced requires the Secretary of Health within 2 months of receiving specified findings and recommendations from the Opioid Restitution Fund Advisory Council to present to the Advisory Council the decisions for allocations from the Opioid Restitution Fund. Within 1 week after the Secretary presents the decisions, the Department of Health must post to their website the Council's findings and recommendations and the Secretary's decisions. The bill expands the permitted uses of ORF funds to include supporting community-based recovery organizations in the state, and requires that in each fiscal year, at least 25% of the money in the Opioid Restitution Fund be used for this purpose. By November 1st of each year, any political subdivision that receives ORF funds must report to the Secretary on the amount of money received that was expended during the preceding year and how the money was spent, and post the report to the political subdivision's website. By December 1st each year, MDH must submit the reports from the political subdivisions to the General Assembly. I know there have been discussions about this bill with the bill sponsor and the department and CADD, and they're here on the call.
Marie Grant.
Thanks, Delegate Bagnall. So we have was talking to Ann Seacott even as late as last night this morning. I think we are in agreement on amendments between the two of us, and I have language that I can shoot over to Council and to you, Delegate Rosenberg, as the sponsor, as soon as we can. There are some amendments around timing that I think we talked about at the last subcommittee meeting. Bumping out to 6 months rather than 2 months when the Secretary needs to report back to the Advisory Council, striking the 25% allocation, and then making some clarifying language around which what kind of providers we're really talking about in the recovery organizations. So I think from our perspective at this point, we're in a pretty good place in terms of agreement with the advocates behind this bill. But I will defer to Ann to keep me honest.
Thank you, Marie. I'm going to go to Ann and then to the bill sponsor, Delegate Rosenberg. So go ahead, Ms. Seacott.
Thank you, Madam Chair. On behalf of NCADD Maryland, we have been able to come to agreement. Just related, it's not part of the bill, but Marie and I also talked about some adjusting some budget language that the Senate has already adopted related to doing a specific look at the programming and funding for recovery organizations. And, I think, these programs still need to have a source of funding, a direct source of funding. But based on the discussions, it sounds like this might not be the year to make that happen. We'll see what the reporting is and what the decisions are with this first round of ORF funding based on recommendations from the ORF Advisory Council.
Thank you. And just to give a little bit of context to the members for this discussion, there's a couple of challenges that we're trying to address. One is the transition from the OOCC to the MOOR, which is in an advisory capacity and making recommendations. And the other is making sure that we are carefully considering what the terms of the settlement agreements are, because they're each settlement is somewhat unique in our ability to utilize those funds. So we want to make sure that we are not running afoul of the settlement agreements, even as we're trying to make sure that we can help support our recovery community. Delegate Rosenberg. Oh, you're on mute, Delegate.
Thank you, Madam Chair. My question has to do, and I'm glad everybody's reached an agreement, what the 6-month timing has, what effect that has on the budget process. So I guess my question is to Marie, what could you do, when does your budget process begin for next year's budget for FY 26 and its relationship to this 6-month period?
Yeah. Thanks, Delegate Rosenberg. So I think and I can also I'm gonna do my best here and then we
I
maybe,
understand.
yeah. So I think the budgeting for the dollars from the ORF overall, my understanding is there is like an allocation and it is set aside as sort of a special fund ORF. And so it's a little bit, in some sense, unless it's being used for other purposes, it's a little bit independent from the overall governor's budget process, timing wise. But in terms of how timing works generally for the budget, the ORF made its recommendations to the secretary, I believe, in early November of this year. Of course, by that time, the governor's budget is actually already well underway in deliberations and development. So it's all, if the recommendations are that late, it's already a little bit late for the immediate fiscal year. The current recommendations that we're considering based on the ORF, I believe, are for FY24 and FY25 right now. And that's what the secretary is working on planning for.
So when this bill assuming we have the 6-month, it has to be, how does that affect next year's decision making? I want to make sure that, starting with the effective date of the bill, that the recommendations from the council board have an impact on the next budget.
Yeah. So I think, Delegate Rosenberg, even without the bill, the recommendations from the ORF Advisory Council have to have an impact on the next budget. As part of the settlement agreements, those recommendations have to be taken into account when the secretary makes the allocation. So when we say within 6 months, she's presenting the decisions and overview, but she has to take into account the recommendations or be at risk for clawback. But she also has to be taking into account, and this is part of the settlement too, is this robust needs assessment across the state.
Okay, thank you.
Thank you, Delegate Rosenberg. Ms. Lowe.
Yeah, can you hear me?
Yes.
Oh, thank you. These organizations, have been in business for more than 15 years, some of them 20 years.
Thank you.
We've never been able to access funding. Back when you allocated money for peer support.
Delegate Rosenberg, you're unmuted. Thank you. Go ahead, Ms.
Peers can get reimbursed under Medicaid, but not peers who work for a peer-founded organization. I mean, there's just been so many barriers year after year. And if we were any other small business in Maryland, we would have equal access to RFPs and funding and Medicaid reimbursement. You know, what's the difference between peers working for a medical provider and peers working for a small business, a small nonprofit that has been in existence for 15 years or more, providing services? I think that the conversation around whether or not we get funding has to include us. And we've kind of been excluded from the table for 15 years. And I'm wondering how we can get into this discussion and make sure that we get to define who we are, what type of organizations we are, what type of services we provide and have been providing as small businesses, small Maryland businesses, established for years providing services. And we would like to weigh in on that definition as to, you know, who these organizations are and what services we provide and how this money will be funded to us finally after being excluded for so long, as if, you know, we're not really doing tons of work here.
Thank you, Ms. Lowe. And I think I saw Marie Grant's hand go up because I think this is part of the conversation and one of the concerns that this committee is very committed to ensuring that we are supporting our recovery community. So Ms. Grant, go ahead.
Yeah, thank you, Delegate Bagnall. Ms. Lowe, I just want to say, I hear you. The department hears you. It is a new administration. I know you have been more than patient. I want you to feel free to reach out to me, just marie.grant@maryland.gov. I want to keep this conversation going. It will be going with this bill. And it will also be going as that budget language that Ms. Seacott mentioned is incredibly comprehensive in terms of like what the department and the commission on behavioral health need to be looking at in terms of recovery services generally and overdose and recovery. So we want to talk to you directly and we hear you.
Could you put your phone number in the chat?
I sure can. I sure can. I will throw
Great.
it in the chat.
Thank you.
Oh, I don't know if I have access to the chat. I'll tell you what, it's 410-598-4533. That's 410-598-4533.
Thanks, Marie. I appreciate it.
Thank you. And just for anyone watching, the Zooms for the General Assembly no longer have the chat feature. So nobody's being excluded. We just don't have it. So, and to our members, you know, I know I sound like a broken record. We are going to hold this bill. We're going to move very quickly tomorrow through these bills because we're having the discussions today. So I don't want folks to worry because we're holding these bills, because we're just holding them so that I can get reprints in front of you. And so we're all very clear on what we're voting on. We have one more bill today, and that is House Bill 1333. This is the Maryland Commission on Health Equity Membership and Statewide Health Equity Plan. Aaron, if you can walk us through the bill and the potential amendments.
The bill requires the Maryland Commission on Health Equity
Actually, my amendment. So, sorry, go ahead.
The bill requires the Maryland Commission on Health Equity using a health equity framework to develop and monitor a statewide health equity plan as required by the Center for Medicare and Medicaid Innovation under any agreement entered into between the state and the Centers for Medicare and Medicaid Services. The commission must coordinate with the Maryland Department of Health and the Health Services Cost Review Commission when establishing an advisory committee. There are amendments that have been provided in a reprint, and then I also know that MDH has one suggested amendment. So the amendment that's been provided in a reprint would actually speak to the current Commission on Public Health, and that amendment would extend the final reporting date of the Commission on Public Health to October 1st, 2025. And then I know that MDH would like to add a member to the commission that is the Maryland Commission on Health Equity.
And do we have someone from Deb Rifkin, are you here on behalf of?
I believe it's Marie would be.
I'm
Oh,
here,
sorry.
but this is probably for Marie, but I'll shake my head yes with whatever Marie says.
Okay, great. Marie, go ahead.
Thank you, Debbie. Thank you, Delegate Bagnall. We were, we reviewed a lot of the testimony, and a lot of folks thought that adding the Community Health Resources Commission to the Commission on Health Equity made a lot of sense, just given their role in the health equity resource communities, and we absolutely agree. So we'd love to add them as a member as well.
All right, and I think that that we would take that as a friendly amendment. Ms. Lowe, your hand is still up. Are you speaking on this bill, or is this just up from previous? Okay, I think it's still up from the previous bill. Yep. So can we have a motion on the amendments, including the addition as proposed by the Maryland Department of Health?
Move the amendment.
Second.
Second.
All right, they've been moved and seconded. Any discussion on the amendments? Seeing none, all in favor of the amendments, say aye.
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 Anyone opposed? Go ahead and raise your hand in the chat. On the bill as amended. Do we have a motion?
Move the bill as amended.
Second.
All right, it's been moved and seconded. Any further discussion? All right, all in favor say aye.
Aye.
Anyone opposed? Go ahead and raise your hand in the chat. All right, House Bill 1333 moves unanimously. So tomorrow we will have the bills that we held over today. We will also have the addition of the baby foods bill. Delegate Taveras, I think it's House Bill
97.
97. And we'll be meeting again, multiple times this week. So just pay attention to your email, listen on the floor. Thank you all for being flexible and for doing so much good work in the off time. And we will get you some reprints today. Delegate Rosenberg.
Do we know when tomorrow, or I understand the flexibility?
11 o'clock, our normal time. So 11 a.m. is we'll have our regular subcommittee meeting, 11 o'clock or as close to after floor as possible.
Thank
and
you.
then we don't know if we will have additional subcommittees this week, so stay tuned. And thank you all for your flexibility. With that, can I have a motion to adjourn?
Move to adjourn.
All right. So it's been
Second.
moved and seconded. We are adjourned. I will see you all on the floor tonight or in the next subcommittee at noon.